As a doctor in training, I was responsible for doing biopsies. And I realized it's a pretty traumatic process for everyone involved. You're inserting a piece of cold steel about 6 to 8 inches long between the ribs to take out a core of liver. First of all, there's the trauma of the process and the hazard and risks involved. But second of all, you're just sampling 1/50,000th of the liver in that core of tissue. So it probably isn't representative of what's going on in the whole entirety of the liver.
Welcome to Healthcare Perspectives, a podcast by Siemens Healthineers about medical breakthroughs with the power to improve lives everywhere. You've just heard Professor William Rosenberg, Deputy Director of the Institute for Liver and Digestive Health at University College London. Here, he explains the realizations that he had as a young doctor performing liver biopsies that made him believe that there must be a better path to diagnosing liver fibrosis. In the second of 2 episodes on liver health, Matt G., Director of Collaborations and External Engagement at Siemens Healthineers, is joined by William Rosenberg, as well as Dr. Veronica Miller, Director of the Forum for Collaborative Research at the University of California, Berkeley School of Public Health, Dr. Arun Sanyal, Professor of Medicine, Physiology, and Molecular Pathology in the Division of Gastroenterology at Virginia Commonwealth University, and Dr. Michelle Long, International Medical Vice President of Metabolic Dysfunction-Associated Steatohepatitis at Novo Nordisk and Director of Clinical Research for the Section of Gastroenterology and Hepatology at Boston University.
Hi, I'm Matt G. Metabolic Dysfunction-Associated Steatotic liver disease, or MASLD, is a chronic liver condition that affects individuals worldwide. In the previous episode on Healthcare Perspectives, we discussed how MASLD develops and the opportunities that exist for earlier identification to prevent progression into more severe forms of the disease. In this episode, we dive deeper into how non-invasive tests are evolving clinical care for MASLD and MASH and challenging the need for liver biopsy, a process that involves removing a tissue sample with a hollow needle and then performing a histological study using a microscopic examination to diagnose and stage disease. I'm joined by experts in the field of liver disease to address how non-invasive tools, including blood tests that assess liver fibrosis, have begun to change both how MASLD patients are supported and how researchers are designing clinical trials of new MASH treatments. For many years, the gold standard for the staging of liver fibrosis has involved biopsy and histology. A higher fibrosis stage determined by liver biopsy reflects a greater risk of developing clinical outcomes, including liver failure, also known as decompensation, liver cancer, and the need for a liver transplant. But just because biopsy has been considered the diagnostic standard for years doesn't mean it's the only way or even the most accurate. As new, non-invasive alternatives to biopsy prove effective, experts are taking the opportunity to challenge the status quo. One commonly used non-invasive test is transient elastography, which is an ultrasound-based method that uses a handheld probe on a patient's skin to create vibrating waves, as explained by Dr. Arun Sanyal and Professor William Rosenberg.
Transient elastography, which measures how stiff the liver is. The stiffer the liver, the greater the chances are that the liver scarred up, and that puts you at greater risk of having bad outcomes.
Transient elastography is a pretty good marker of severity of liver fibrosis on the day. If you account for all potential confounding factors like obesity and inflammation and eating, feeding effects, alcohol, and so forth, we know that a transient elastography reading will give you a pretty good idea of structural liver damage.
Along with transient elastography, there's a blood test called the Enhanced Liver Fibrosis Test, or the ELF test, that measures 3 direct markers of liver fibrosis: hyaluronic acid, type 3 procollagen peptide, and tissue inhibitor of matrix metalloproteinase 1. As co-inventor of the ELF test, William Rosenberg describes the decades-long process to develop and validate the device.
In the late 1990s, I started to work with a group of doctors who had primarily been working in basic science, understanding the biology of liver fibrosis. And through their work, they had identified a number of potential biomarkers that were produced during the process of fibrosis synthesis and degradation.
The hunt was on for the right combination of biomarkers to assess liver fibrosis and be a potential alternative to long-favored biopsies.
There were a number of what we would call direct biomarkers of liver fibrosis. These are molecules involved in collagen synthesis and degradation in the liver, either constituents of matrix or enzymes involved in matrix synthesis and degradation. But there were also a large number of other indirect markers of liver fibrosis. It was known that markers of liver inflammation correlated to some degree with fibrosis severity. So we set out to assess well over 30 different biomarkers, some direct biomarkers, some indirect biomarkers, and to look at the levels of those biomarkers in blood. We'll look for correlations with liver biopsies analyzed using really careful histology. And the aim was to try and get a minimum set of biomarkers that would correlate with liver histology. It became apparent at that stage that using biomarkers in combinations was far more accurate than using them individually. And that's really predicated on the performance of the individual biomarkers, what they measure differently, and so in combination give a fuller picture, and how they perform when used together.
And the outcome of this work was the ELF test. However, to be as useful as liver biopsy, non-invasive tests like the ELF test must address biopsy's rules, especially its value as a prognostic tool to assess a patient's risk of progression to cirrhosis and liver-related clinical outcomes.
As a prognostic, do these biomarkers predict what is going to happen over a long period of time in the same way that we knew at that stage that liver biopsy histology gave us some idea of what was going to happen in the future? Whilst liver biopsy is a very good prognostic, ELF was better at predicting what was going to happen to patients in our study over the next 10 years than liver histology. Now, that was a surprise, but on the basis of that study we conducted in 2010, following up the original cohort, we actually saw that ELF is better than histology as a prognostic test.
It's important that different non-invasive tests measure unique aspects of liver fibrosis. The ELF test measures liver biochemistry, and transient elastography detects structural changes in the liver. For Arun Sanyal, having both the ELF test and transient elastography is a powerful combination.
Together, they provide better information than either one alone, but either looking at liver stiffness or looking at the ELF test gives us additional data on the risk of an outcome. So those who have high risk, that's a population that for sure you should send on to a hepatology because there's a high likelihood they have cirrhosis. And not only do they have cirrhosis, that a liver outcome is imminent. And so that population should go to a liver doctor. I think elastography and the ELF test provide a lot of value.
In fact, even before testing with ELF or transient elastography, it is possible to do a liver fibrosis risk assessment by starting with an easy calculation called the Fibrosis-4 or FIB-4 score based on common blood tests.
There's been an incredible explosion of information and data over the last 10 years around risk stratification and to identify which patients are at the greatest risk of developing an adverse liver outcome. And a starting point in relatively asymptomatic people who have risk factors for MASLD, such as obesity, diabetes, hypertension, etc. A good starting point is to compute the FIB-4 score. FIB-4 stands for Fibrosis 4 and is based on your age, 2 liver enzyme tests called the AST and ALT, which are part of a hepatic panel, and the platelet count, which is part of your blood counts when you get your hemoglobin done.
Something as simple as calculating the score at an annual visit could potentially save a patient from more costly invasive and time-consuming testing. William Rosenberg and his team at the University College London showed that a non-invasive approach involving FIB-4 and the ELF test could substantially reduce unnecessary referrals and increase detection of patients that are most at risk of liver-related clinical outcomes.
When we introduced the pathway, we introduced it as standard of care. What we evaluated was the new pathway, and so it became standard practice at that stage, and it's remained as standard practice over the next 10 years or so. We've been able to continuously evaluate its performance, and it continues to perform in the same way. 80% reduction in unnecessary referrals and a 5-fold pickup in advanced liver disease detection. And it's highly cost effective. It's reduced the cost of liver care in the area. It's very well received by the primary care physicians delivering the care and by the patients who are subjected to that pathway.
In 2024, Rezdiffra, the first pharmaceutical treatment for MASH, was approved by the US Food and Drug Administration. As part of FDA's approval, there was no requirement to use biopsy to determine liver fibrosis stage. This opened the possibility of using non-invasive tests like the ELF test and liver stiffness measurement by transient elastography to identify patients who might qualify for treatment. Again, here's Arun Sanyal.
If you identify that the ELF score is over 9.8, or if the elastography values are elevated above 10, it identifies a population that is at increased risk of outcomes. There are now drugs available with which these patients can be treated. And so that is the population where the testing provides very important information that not only tells you that they need to be sent to a hepatologist, but actually there are drugs available for these patients that can turn the ship around.
Getting to an approved therapy for MASH is an incredible milestone. A big challenge has been defining a consensus about which patients qualify for clinical trials and the most appropriate measures of drug effectiveness. As the director of the Forum for Collaborative Research, Dr. Veronica Miller has helmed the Liver Forum, which identifies science-based solutions to facilitate drug development. This group, comprised of researchers from academia and industry, regulators, and patient advocates, has identified non-invasive tests as a key factor in optimizing clinical trial design.
We had a meeting and I asked everyone, what is your main ask of the Liver Forum? And everyone said non-invasive tools, non-invasive tests to get rid of the biopsy. So the biopsy was recognized from the very beginning as being this stumbling block. Not making it impossible, but the industry saw very, very clearly that going through the biopsy pathway was just not really very good. We focused a lot on, even in biopsy, how can we refine the definitions? And we started off with papers on how do we define the different stages and the process of progression, and then you had regression happening naturally. So really defining that more succinctly in terms of the different stages and the processes as we move forward. Then I think also starting to address the question of, are we going to develop non-invasive tests to correlate with biopsy or with clinical endpoints?
As a co-chair of the Liver Forum, Arun Sanyal also sees a path forward for non-invasive tests, or NITs, to serve a greater role in drug clinical trials.
There is a hierarchy within the biomarker space, or the NITs, in terms of the information they provide. So the simplest one is diagnostic, but then you have prognostic, then there's disease monitoring, treatment response, and all of this eventually sitting at the top is what's called a surrogate endpoint for clinical outcomes. And there are two types of surrogate endpoints. There's something called a reasonably likely surrogate endpoint, and then there are generally accepted surrogate endpoints. So a generally accepted surrogate endpoint is very much like a clinical outcome, which tells you that your intervention has improved how a patient feels, functions, or survives. But it's a high bar. You need a lot of data to actually get something approved as a generally validated. Now, there is a lower bar to get what's called a reasonably likely surrogate endpoint, or an RLSE. And an RLSE basically has all of the same components, but the total amount of information or data that you need is less, so that it makes a reasonably likely story that the short-term changes that you see with these non-invasive tests will translate into clinical benefit in the long term. But what we need are the data sets to show that something you can measure within 1 year as a clinical outcome using an NIT.
When it comes to assessing the effectiveness of new treatments for MASH in a clinical trial, the main endpoint to demonstrate that a drug is effective is based on whether or not the number of liver-related clinical outcomes is reduced in patients. Many regulators now allow the possibility for a drug to be initially approved if it can be demonstrated that the drug meets reasonably likely surrogate endpoints of resolution of MASH and reversal of liver fibrosis stage as determined by biopsy. Dr. Michelle Long, International Medical Vice President of Metabolic Dysfunction-Associated Steatohepatitis at Novo Nordisk, has watched the evolution of accepted clinical trial endpoints firsthand.
I can remember these discussions where we're talking so much about MASH resolution, and the emphasis was so strong on MASH resolution because we believed in the pathophysiology, and we believed that if you impact MASH, that of course that's going to have downstream effects on fibrosis. It's not likely that you'd be able to show that in 6 months or a year or even potentially 2 years. This was the thinking at the time. And so there was this huge emphasis on MASH resolution and so much supportive evidence for that, but really no hard clinical evidence that impacting MASH resolution is going to improve outcomes. Then we start to see, actually, wait a second, we maybe could have an impact on fibrosis in a shorter period of time. This is coming from the days when no one thought cirrhosis could be reversed.
The reliance on biopsy in clinical trials, while it makes intuitive sense, has its challenges.
If the outcome in the study is development of cirrhosis, if we can agree that that's an important event, because we know that means you're ultimately at risk for getting subsequent events and decompensated cirrhosis. So then it makes sense that if you disrupt that pathway and you prevent in a stepwise manner getting cirrhosis, then you're ultimately slowing down or reversing that endpoint. It came from early observations that it was thought that fibrosis could more reliably be measured on histology, or at least agreed upon between pathologists. This, of course, subsequently has not been shown to be the case. There's still a lot of variability there in opinion of staging fibrosis.
Despite the challenges with biopsies in clinical trials, regulators are not yet ready to rely on non-invasive testing alone to determine drug effectiveness. Here again is William Rosenberg.
The key thing to recognize is that the regulators are very conservative for very good reasons. They are charged with protecting the well-being of the population. So they are going to need a lot of persuading before they change from what has been a tried and tested method of diagnosis and adopt something new. And liver biopsy is really woven into the creation of hepatology as a specialty. The very dawning of hepatology was based on the ability to look at the liver and study it using histology. And I think it is because things are so well established against liver histology that it remains the reference standard that the regulators prefer.
But with time and more common usage, the tide with regulators seems to be changing, slowly but surely.
I've been attending meetings over the last 20 or more, 25 years with the regulators to review the progress of new non-invasive tests in the context of clinical trials. And I think we're really at the dawning of a new era, because the studies that have been conducted in metabolic-associated steatotic liver disease have incorporated non-invasive tests alongside histology, and they're beginning to demonstrate that the non-invasive tests are at least as good as histology in detecting changes in fibrosis. I've come to recognize liver histology in itself as a surrogate marker for what really matters to patients, which is clinical outcomes. Now, when you start to produce evidence that shows that non-invasive tests are better predictors of truly important clinical outcomes than histology, then you start to get into a realm where you say, well, now's the time to abandon histology because actually it's imposing a glass ceiling on performance.
Although the benefits of using non-invasive tests to measure drug effectiveness are becoming clear, more work is needed to validate these tests for this purpose.
I think we need more outcome data. I'd like to see more NITs linking into outcomes and less into specific fibrosis stages. We need to better understand across different potential mechanisms how the NITs work. Also, At what point in time can you see a change in a non-invasive test? And is that predictive of a durable response or result? And the magnitude of change that we should be looking for. So there are many questions. We need more data to understand the tools that we have and that have been developed so that we put them to best use.
For Veronica Miller and the Liver Forum, it seems that we've now reached a tipping point where regulators may soon be open to a non-invasive approach in clinical trials.
We are at the point where we're saying reasonably likely, and I think there's consensus that fibrosis, bridging fibrosis, cirrhosis, leading to decompensated cirrhosis as a process is really what is the pathway. We're looking at both physical tests of liver stiffness and circulating biomarker tests. The field is moving. There's a lot of research going on.
Pharmaceutical companies have long been working towards bringing to market therapeutic options that would support patients with liver disease.
What we haven't discovered yet is utterly reliable drugs that hit targets that lead to fibrosis reversal through the mechanism of fibrosis. But what we are beginning to recognize is, first of all, drugs that remove the causes of liver damage. So the antiviral drugs would be indicative of that. So drugs for hepatitis B and hepatitis C have really transformed the prognosis in those conditions because they prevent the inflammatory basis of the liver injury and therefore prevent fibrosis progression, allow the liver to repair. In MASLD, MASH, we've started to see a number of drugs come through which have very widespread effects as it transpires in affecting the underlying process that drives liver fibrosis in steatotic liver disease. And those drugs clearly enable the liver to repair once the inflammatory insult is removed. I don't think we've yet got to the point where we can give a drug that, irrespective of the driver of the liver damage, will reverse fibrosis. But we certainly now have highly effective drugs as it transpires in the regions of viral hepatitis, MASLD, and alcohol-related liver disease as it transpires with these GLP-1 receptor agonists that influence the inflammatory process and thereby allow the liver to repair.
For Veronica Miller, too, the future of antifibrotic treatments hinge on the varying causes of liver disease.
Many drugs are in the pipeline, really starting to look at what combination treatments might be considered, who should we consider them for, what happens when you have different etiologies, and I include alcohol, of course, but also I think we really need to start thinking about liver toxins that so many people are exposed to. I think we really need to acknowledge that there are many liver poisons out there that can affect how MASH, MASLD progress.
Liver fibrosis, once thought to be an inevitable progression to liver failure, cancer, and transplantation, now has the potential to be reversed.
That opened the doorway to increased emphasis on trying to detect liver fibrosis before cirrhosis develops or at the very earliest stages of fibrosis, hence our quest for non-invasive tests.
For William Rosenberg, the introduction of non-invasive testing doesn't mean continuing to chase more tests for marginal gains. It means better care now for those with liver diseases.
Rather than looking for more and more marginally better tests, what I'm really keen to do is see how we can use the tests that we've got that are good in influencing the way we practice patient care. So I have a lot of debates with colleagues who say, oh yeah, but ELF test isn't that sensitive or specific, and transient elastography is pretty good, but it's not that sensitive or specific. Let's go after better tests. That study we did in North Central London, managing care of patients using the non-invasive tests that we currently have, showed how very effective the tests that we have at the moment can be in altering and improving the way we care for patients. What I would caution is it takes a very, very long time to build up a body of evidence that can underwrite the performance of a good diagnostic test. Don't be distracted away from thinking about how you might use them to benefit the patients who are in the clinics today and tomorrow. You may develop a marginally better test that may have a marginal difference in the way we manage patients in 10, 20 years' time. But think how many patients are going to pass through our care between now and then.
And at the Liver Forum, the hurdles that Veronica Miller sees with the future treatment of liver fibrosis hinge greatly on the ability for scientists around the globe to collaborate their findings.
I think we need to really look at this globally. What I keep saying is keep working on the science and let the science be ready for when the agency is ready. But also really look globally to strengthen our relationship with the European regulatory network across Europe and also in the Asian region. So what I see right now is we need to get this reasonably likely endpoint accepted across the world and then really stick with it and bring it to the fully accepted or validated or just a surrogate endpoint, no longer reasonably likely, really taking away that reasonably likely bit of doubt and uncertainty that remains.
In the past, suspicion of a fatty liver meant an invasive, costly, and often painful biopsy to diagnose and treat. The reliance on biopsy also complicates drug development of new MASH treatments. Significant improvement in the understanding of liver disease progression, the introduction of non-invasive clinical pathways, and pharmaceutical advancements in the field mean that the road to recovery and repair from liver fibrosis has never been more clear.
There is always hope. The liver is the best organ in the body. There are a number of reasons, but one of them is the liver's ability to regenerate itself. So even if you present with cirrhosis, provided the insult that's led to the cirrhosis is removed, there is plenty of opportunity for the liver to stabilize or even regenerate to the point at which life expectancy approximates back to normal.
You've been listening to Healthcare Perspectives, a podcast by Siemens Healthineers. We pioneer breakthroughs in healthcare for everyone, everywhere, sustainably. Subscribe to us and always get the latest episode in your podcast feed. Or visit siemens-healthineers.com/podcast for more. The opinions expressed by the guests and contributors in this podcast are their own and do not necessarily reflect the views of Siemens Healthineers. The statements by Siemens Healthineers customers in this podcast are based on results that were achieved in the customer's unique setting. Because there is no typical hospital or laboratory, and many variables exist, for example, hospital size, samples mix, case mix, level of IT, and/or automation adoption, there can be no guarantee that the other customers will achieve the same results. This podcast describes possible future ideas and concepts. It is not intended to describe specific performance and/or safety characteristics of currently planned or future products. Future realization and availability cannot be guaranteed.